Good afternoon. Before we begin, I'd like to acknowledge that Dalhousie University is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq, and I'd like to pay my respects to the elders. Welcome to our Open Dialogue live event today. I'm your host, Joanne Bath, CEO of the Dalhousie Medical Research Foundation. If you haven't heard of us already, our foundation was created over 40 years ago by several community leaders who believed in the power of local health research to change and save lives. They also believed that health research could bring outstanding talent and economic opportunity to this region. Since then, Dalhousie Medical Research Foundation has raised tens of millions of dollars to support local health research excellence. In fact, we're on the heels of our most successful year to date, having granted more than $6 million to 200 noteworthy health research projects. We could not have made this happen without the generosity and commitment of our donors. Philanthropy is needed to advance health research into real-life outcomes. Our foundation fundraises to provide the best resources available to bolster our researchers' leading-edge work. For example, we were able to quickly respond during the COVID-19 global health pandemic in the early days, contributing $250,000 from our endowment, which helped to unlock federal funding, as well as additional funding from our great partner at Research Nova Scotia. Beyond that, we quickly teamed up with several key organizations across Nova Scotia to form the Nova Scotia COVID-19 Health Research Coalition. From clinical sciences to health systems improvement related to the coronavirus, a total of 262 researchers applied to this coalition for funding. The coalition made a collective investment of $1.5 million that was distributed to 40 COVID-19 research teams, and this is a shining example of philanthropy at work. Aside from timely and imperative COVID-19 research, DMRF continues to raise funds that support research in the areas of cancer, cardiac care, Alzheimer's, inherited childhood diseases, mental health, infectious disease, as well as advancing health equity for vulnerable populations and improving access to care, and even in the area of pain, which you'll hear more about today. These are just a few examples of the many health research areas that we're proud to support. And we truly couldn't do this without the dedication of our donors and our community who come together to support the great work that we do. Today's event is titled, Everybody Hurts, Understanding Pain from Birth to the End of Life. As we know, pain is a reality we all must face, but that doesn't mean that there aren't ways to better manage that pain. Personally, I've experienced the challenges of pain associated with endometriosis. This is a condition that is under-researched and has very few support systems in place, particularly as it relates to the extreme and acute chronic pain involved. Pain is real, and it is as emotionally taxing and mentally taxing as it is physically draining. We understand this and recognize it to be a crucial area of health research. That's why today, Dalhousie Medical Research Foundation is proud to feature 3 leading researchers who are working to advance our understanding of pain and what can be done about it. For today's Open Dialogue episode, we'll learn from experts regarding pain throughout the life. First, we'll hear from Dr. Christine Chambers speaking about children's pain. Second, Dr. Natalie Rosen, who will talk about sexual pain. And finally, Dr. Shanna Treneman, who will be speaking on treating pain in older adults. There will be time for questions and answers at the end following all of the presentations, so please submit your questions and we'll do our best to get through them. So let's get started. We begin today with Dr. Christine Chambers. Christine is a Tier 1 Canada Research Chair in Children's Pain and a Killam Professor in the Departments of Pediatrics and Psychology and Neuroscience at Dalhousie University. In 2019, Christine led the launch of Solutions for Kids in Pain, or SKIP, a new knowledge mobilization network to help improve children's pain care. Headquartered at Dalhousie, SKIP's mission is to improve children's pain management by mobilizing evidence-based solutions through coordination and collaboration. Welcome, Christine.
Thanks, Joanne. It's really a pleasure to be here today. Looking forward to sharing a little bit about our research. I just need the slides, I think. There we go. Perfect. Thanks so much. Next slide, please. I wanted to introduce you today to Elijah. He was born 3 months early, weighing only 1 pound, 8 ounces, and spent the first 4 months of his life in the neonatal intensive care unit, also known as the NICU. Research has shown that babies in the NICU undergo an average of 16 painful procedures every day, and Elijah was no exception. In the first 6 weeks of his life, he experienced 858 painful medical procedures and surgeries. Luckily, Elijah was born only a few years ago, but if he had been born 40 years ago, he would have undergone all of these procedures with no pain management or anesthesia whatsoever. Next slide. That's right, as recently as the 1970s and 80s, it was widely believed that babies, especially premature babies, couldn't feel pain and that it was too risky to use anesthetics with them. Babies were given paralytics so they wouldn't move during surgery. They were given nothing for pain. So how did things change? It took the combined power of science and one brave mother to make a difference. Research in the 1980s found that babies who received inadequate anesthesia after surgery had more complications and were more likely to die after surgery than those whose pain was properly managed. And around the same time as this research was conducted, Jill Lawson, a mother whose premature baby died shortly after surgery, went public with her son's inadequate pain care. So this was the headline in the newspaper: "Surgery without anesthesia, can preemies feel pain?" There was a major public outcry. I mean, people couldn't believe that this could be happening because every parent knows that babies feel pain. So the practice quickly became unacceptable. While we've come a long way, there are still many ways that we continue to fail children when it comes to pain. Best available evidence is still rarely used in practice. Take, for example, a big topic right now in this pandemic: vaccinations. No parent likes taking their child for needles, but by age 5, children will have had as many as 24 standard vaccinations. There are effective ways to reduce needle pain. However, fewer than 5% of children receive any kind of pain management for vaccinations. And this really causes children to develop a fear of needles, can result in them avoiding going to the doctor and getting appropriate medical care for the rest of their lives. As another example, take chronic pain. 1 in 5 Canadian children experiences headaches, stomach aches, or joint pain at least once a week. And 1 in 20 children are so disabled by their pain that they miss school, and it negatively impacts their relationships with family and friends. We know that intensive team treatment works best for children with pain. However, very few children with chronic pain ever get access to the kind of pain treatment they deserve. So why aren't children getting the right kind of pain management? Part of the problem is that there are lots of wrong ideas about pain. Some people believe that pain has no long-lasting effects, but that isn't true. Research has shown that early, poorly managed painful experiences really changes the way children's brains and bodies experience pain and can make them become more sensitive to pain. Another part of the problem is that health professionals don't get much training about pain. One study found that veterinarians receive 5 times more training in pain than doctors do. So in theory, your dog could get better pain management than your child. My own research over the last 20 years has focused on the role of parents in children's pain. In this picture, you can see it's the baby getting the needle, but it's the father who's feeling the child's pain. And my research has focused on what parents say and do and how that influences their children's pain experience. Over the last 15 years, my own 4 children have taken me to the front lines of pain management with emergency department visits, medical procedures, and surgeries. And I was shocked to realize that the results of the research that I had spent my whole career, publishing and contributing to, weren't being used in practice to benefit my own children. There were times where I had to advocate really strongly for my children to receive what I knew to be evidence-based pain management. My husband's an anesthesiologist, so we're kind of like an interdisciplinary pain management team. It made me wonder, where does that leave every other parent who assumes that everything possible is already being done to help their child with pain? So as part of a fellowship I completed in media and advocacy, I decided that I wanted to reach parents directly with evidence-based information about pain. We created a fun, short YouTube video for parents called "It Doesn't Have to Hurt." In the video, a young girl teaches parents simple things that they can do to make needle procedures like vaccinations easier, using an anesthetic cream, using distraction, using relaxation. For parents, watching the kind of language that they use. Some things that parents say, like reassuring statements, can actually make children's pain worse. Parents love the video. They gave us feedback like, "My kids got their flu shots today, and the advice from your video really made a difference." Although the video was getting a lot of views online, I wanted to reach more people, so I started tweeting. I learned very quickly that when I was able to engage influencers with large followings, such as journalists or parenting media, the message spread faster. I started targeting influencers like Erica M., a former national Canadian TV host with an online community for mothers called Yummy Mummy Club, or YMC. To my surprise, she replied, said she loved the video, and asked if they could write about it. When the YMC blog post went live, we noticed a huge jump in the number of views of our video. So that gave me an idea if perhaps we as scientists could work in partnership with those who are already creating content for parents. We could even reach more people. So I reached out to Erica, whose YMC platform reaches over 6 million parents a month, and we submitted a grant to the Canadian Institutes of Health Research. With this grant together, we developed "It Doesn't Have to Hurt," a branded social media initiative whose goal was to increase parent awareness and use of research evidence about children's pain. A panel of parent partners helped identify areas of information need. Researchers created evidence summaries on each of the topics, and then YMC literally knowledge translated that information into parent-friendly content and shared it through their network. We had lots of different other partners also who were involved in helping share. These are some examples of the "It Doesn't Have to Hurt" content, blog posts. You can see that we really used parent storytelling to seamlessly integrate evidence-based information. Some of my favorites were the Instagram images, dozens of randomized trials synthesized into systematic reviews, all summed up with 3 words: breastfeeding and needles equals "It doesn't have to hurt." Following the success of this initiative, I wanted to use this partnership model to improve children's pain management to different knowledge users and with the support of different other partners. So when the Networks of Centers of Excellence announced a funding competition dedicated to knowledge mobilization, it was the perfect match. I, along with a team of researchers, parent partners, and partnering organizations, applied with the vision of supporting healthier Canadians through better pain management. We were successful, and in 2019, we established Solutions for Kids in Pain, also known as SKIP. SKIP is a national knowledge mobilization network based at Dalhousie University and is incorporated as a not-for-profit organization. SKIP's mission is to improve children's pain management by mobilizing evidence-based solutions through coordination and collaboration. SKIP has regional hubs across the country where a SKIP hub lead and knowledge broker work together to support knowledge mobilization in their region. SKIP also has, on the next slide, over 100 national and international partners, including the DMRF, who are working with us to help achieve our goal. The DMRF, we were thrilled, is featuring SKIP this spring during their annual Molly Appeal campaign so that we can all continue to work together to help kids in pain. SKIP engages hundreds of activities to support readiness, resources and evidence, tool production and promotion, facilitating change, and creating a sense of awareness and urgency around the problem of pain in children. Lots of examples of work that we've done include creating a national database of patient partners, scaling and spreading effective innovations for pain, and helping researchers incorporate knowledge mobilization strategies into their own research. And SKIP is making a difference. We are just wrapping our second year of activities, but from our first year, you can see lots of evidence of different engagements and different activities, and would encourage you all to visit our new kidsinpain.ca website. So I'll conclude today by circling back to Elijah, the little baby I introduced you to at the beginning of my presentation. This is Elijah with his twin brother, Hayden, a few years later. It's time we think differently about children's pain. As we're doing with SKIP, we need to work together as scientists, health professionals, parents, families, and friends to change the way we think about pain and ensure our children get the pain care they deserve. Because I believe, and many of my colleagues as well, that it doesn't have to hurt. Thank you.
Thank you, Christine. So appreciate that presentation, and the importance of your research involving children truly cannot be understated. So thank you, and we're really proud to be associated with the work that you're doing. Next, I'd like to introduce Dr. Natalie Rosen. Natalie is a clinical psychologist and associate professor in Dalhousie's Department of Psychology and Neuroscience and the Department of Obstetrics and Gynaecology. She also holds a professorship in sexual health in couples, supported by DMRF and the Department of Obstetrics and Gynaecology. Natalie is here to discuss her research on the causes, consequences, and treatment of pain experienced during sexual activity. Welcome, Natalie.
Thank you for having me. I'll just wait a minute for my slides to come up. That's great. There they are. So yes, I'm going to talk about a little bit more of an intimate topic today, and one that doesn't often get featured in sort of these public forums, but you'll hear a little bit about why I think it's important that it is. So it's actually a much more common problem than you might expect. In fact, about 1 in 5 young women, so under the age of 30, report chronically experiencing pain during sexual activity in the previous year. And that number goes up to just over a third of women aged over 45, so in that sort of perimenopausal or postmenopausal age. Despite this really high prevalence, only about 60% of women who report experiencing this problem ever seek any kind of treatment. And of those women who seek treatment, only half ever receive a formal diagnosis. So clearly with the prevalence rates and sort of that treatment-seeking difficulties, there's still quite a need to increase knowledge and access to service for women suffering from this problem. So I wanted to then give you a little bit of a sense of what it looks like to talk to some of the women and their partners who are experiencing this problem. So I hear things like, since the pain started, sex and pain are inextricably linked. I do everything possible to avoid being intimate with my partner because of the pain. I feel guilty and ashamed. All I want is to have a normal sex life with the person I love. I feel like we've been cheated. He's so supportive, but I worry that he's looking elsewhere. Partners of women also are impacted. So we hear things like, I feel guilty for wanting sex. I'm not sure how to be supportive without just accepting that we can't have sex. Apart from this side of the relationship, everything else is going great. And I don't want to hurt her. So clearly there is quite a bit of distress associated with this problem and also sexual dysfunction. So for women, the consequences go beyond just the pain to impact all aspects of their sexuality. They report lower relationship satisfaction, more distress, and a lot of guilt and shame, feelings of isolation associated with this problem. The partners also report consequences, importantly, a negative toll on their relationships, some more sexual difficulties, and also increased psychological distress. I want to say a little bit about causes of vulvar pain. So they tend to be categorized into 2 types. So what you see here on the first sort of type, that's when the pain is caused by a specific disorder. So when we can actually pinpoint, the reason for the pain. So whether it's an infection, trauma, an inflammatory or skin problem, and particularly for women around menopause, we know that there are some hormonal changes that can be a cause of this pain occurring. The second category of causes is what's called vulvodynia. So this is when the pain has lasted at least 3 months, but we can't identify a specific cause of it. So the gynecological exam or other examinations might turn up nothing. So it's hard to sort of identify the cause. But what we know is that for both of these types of pain, the cause is typically a combination of biological, psychological, and social factors, both in terms of the cause, but also what's keeping the pain going, what's maintaining it over time. In terms of treatment, and for the vulvodynia in particular, and I'll say a little bit more about this a little later, the first line medical treatment tends to be a topical lidocaine, which is like an anesthetic ointment. There's some mixed evidence to support other types of medications as well. For postmenopausal pain, a local estrogen, which is really targeting that hormonal deficiency that's related to the pain. But for all women who are experiencing this type of pain related to sexual activity, there's really strong evidence for non-medical approaches, so including pelvic floor physical therapy and also cognitive behavioral therapy, which is a psychological approach. So what I want to spend my sort of second half telling you about today are the results from a recently completed and published study that we've been working on for a number of years, looking at cognitive behavioral couple therapy for what's called provoked vestibulodynia, which is a bit of a mouthful, so we'll call it PVD, which is the most common subtype of that vulvodynia type of pain. It has a prevalence of 8%, which is really shocking given that I would venture bet that most people in the audience today might never have heard of PVD. That's 8% of all women. And it's characterized by a burning or cutting pain that's specifically upon pressure at the entrance of the vagina. So mostly triggered during sexual activity, but also other things like trying to insert a tampon or riding a bicycle, or even some women talk about wearing like tight jeans, that it triggers the pain. So why did we want to take a couple-based approach to this? So as I just mentioned, the pain is most often triggered during partnered sexual activity. And as I also mentioned, the partners are impacted. So they witness the pain. Often they'll talk about, like, I feel like I'm the one who's causing the pain. And they have their own reactions to the pain. Over the last 10 years, myself and my colleagues have conducted an extensive amount of research looking at relationship dynamics and how the couple's communicating about the pain, what they're doing together, and how that influences their outcomes. What about CBT then? Why did we choose this approach? Of the different treatment options, CBT is really the only one that directly targets the negative sexual and relationship consequences associated with the problem. We also know that these cognitive behavioral strategies are effective in reducing pain in other pain conditions. And some prior work has also found that group-based CBT with the women who are experiencing the pain is an effective treatment. So what we did was a randomized clinical trial conducted here in Halifax and also a second site in Montreal. The comparison group was that topical lidocaine that I mentioned, and the couples who participated completed surveys before treatment, after treatment, and 6 months later. There were 108 couples who were randomized to one of the two treatment conditions. In the couple therapy, they attended 12 75-minute sessions of the treatment. All the women have been diagnosed with PVD. The therapists were PhD students in clinical psychology who were supervised by a registered psychologist. And they delivered a standardized treatment manual that we developed based on our research. All of the sessions were also videotaped so that we could look back and check, were the therapists actually following the treatment manual? This gives you sort of an overview of what we were targeting and doing in the treatment. You can see that there was a real emphasis on couple communication, increasing pleasurable sexual experiences. They learned coping strategies for better managing the pain, and alongside some education type interventions as well. The comparison group was that lidocaine, so it's a topical ointment that women applied nightly for 12 weeks. It was prescribed and sort of monitored by our study gynecologist, and the women in this group also received a little bit of sort of basic psychoeducation around day-to-day management of PVD. Okay, so the next little series is a couple of sort of more scientific graphs. Let me just orient you to what you're looking at, but I'm going to just highlight the key messages. So the orange bars there are the couple therapy. The turquoise bars are the lidocaine. And you'll see at the bottom groupings of sort of the pre-treatment, the post-treatment, and then the follow-up, which is the 6 month later. So at pre-treatment, this is pain during intercourse, the intensity of the pain. There's no differences between the two groups. And what you see is a significant decrease in their pain, both at post-treatment and maintained 6 months later, but with no differences between the two groups. So each group was doing equally well in terms of the reduction in pain intensity. This next slide is another pain measure, but it's a measure of pain unpleasantness. So the way I like to think about this measure is it's the sort of emotional response to the pain or the degree of suffering kind of thing that women are reporting. And again, there's no differences between the groups before treatment. Both groups reduce significantly in terms of women's pain unpleasantness, but at the 6 month follow-up, the women in the couple therapy, their pain unpleasantness is lower, significantly lower in the lidocaine, where it kind of starts to creep a little bit back up again. This slide shows sexual distress. So that's another key outcome. So how much anxiety, worry, distress around their sexuality are they experiencing? So on the left, there was women. And what we saw is that there was a much more significant reduction in their sexual distress in the couple therapy condition at post-treatment relative to the lidocaine, but it evens out a little bit 6 months later. Still much lower than pre-treatment, but no differences anymore. The partners on the right, they weren't as distressed to begin with, which we can, understand, but their distress reduced to the same degree in both of the conditions. This one here shows when we asked the women and partners, how satisfied were they with the treatment? What did they find? And what you see here is that there was quite a lot higher satisfaction with treatment in the couple therapy condition, both for women and partners and both post-treatment and 6 months later. And then this last one is when we asked them, what was their impression of how much they improved in terms of their sexuality and in terms of their pain. And again, on the left there, we saw that for both women and partners, they saw themselves as improving in terms of their sexuality, much more so in the couple therapy than in the lidocaine. A little bit, no difference in the follow-up for partners. And then back one. Not done, sorry. We didn't, though, when we asked women and partners, how much did they feel like their pain improved, despite the fact that we saw these differences in sort of their self-reports on pain measures, there wasn't any differences then between the two groups for women and partners for their own impression of change in pain. So what can we conclude from this? For women, the couple therapy resulted in significantly greater reductions in pain unpleasantness, and also a couple of other pain measures that I didn't have time to talk about a lot here about pain, how much they catastrophize, their anxiety around the pain was better in the couple therapy in terms of reducing, along with the sexual distress. For both women and partners, they reported more treatment satisfaction in the couple therapy and greater subjective improvements in their sexuality. And importantly, the partners, they're not the ones with the pain, but they were also showing a lot of benefits from both treatments. So the couple therapy is just as effective as a first-line medical treatment. And this evidence is suggesting that it can also be recommended as a new treatment tool. The last thing I kind of wanted to mention is that we, of course, conducted this research within the confines of a very structured treatment program where we're following the structured treatment manual. And in actual practice, when therapists see couples, they're more likely to be able to tailor it even more so to the couple's needs, go at different paces, which may even provide better outcomes for couples. I just wanted to mention that, this type of research takes a big team. So these are some acknowledgements around the funding bodies and the collaborators who worked on this project. And last slide. And yes, and this is just my contact information. And I'll just mention that also on the website, there's a number of resources around vulvar pain and vulvar pain management as well for anyone who's interested.
Thank you, Natalie. So appreciate your time, and again, can't underscore enough the importance of this research area that I know we don't talk about enough. So we really appreciate you bringing bringing it into focus for us. Our third presenter today is Dr. Shanna Treneman. Shanna is a postdoctoral fellow with Geriatric Medicine Research who is studying how medication exposure influences the development of dementia-related neuropathologies. Shanna also practices as a hospital pharmacist at the Dartmouth General Hospital, another great partner of ours. Shanna completed her Bachelor of Science in Pharmacy, Master's in Applied Health Research, and interdisciplinary PhD at Dalhousie. Today, she'll be discussing her research and clinical experience regarding appropriate drug use in older adults through the lens of pain management and quality of life. Welcome, Shanna.
Thank you, and thank you for those kind words of introduction. I'd also like to thank my fellow panelists for starting our journey of pain experiences along the course of life. So wait for my slides to show up. Just remind you all that I have the responsibility of discussing pain in older adults, and due to my background as a clinical pharmacist and a researcher, I will be talking about the medications that treat pain and introducing specific considerations for pain and its management in older adults. Looking at my next slide, yeah, right there, I want to start by mentioning that pain is personal and it is experienced differently by different people. The best example I have of this comes from the continuous one-upmanship of emergency department physicians who share on Twitter their run-ins with farmers who have a seemingly extreme tolerance to pain and injury. Now, I can comment on the truth of this, not as a healthcare professional, but as the daughter of a farmer. And my cattle farmer father once fell out of the hayloft, broke his arm, and then drove his standard truck to his day job, not the hospital. He did get there eventually, and that's just one story. Older adults can run into pain in a variety of ways. There's acute pains like stubbed toes, headaches. Oh, you can go back to that picture there, yeah. There are chronic pains like arthritis, acute pains like stubbed toes, headaches, and broken bones. Those are the acute ones. And then the chronic pains like the arthritis, pain complications from shingles, pain from injuries that persist. And in the short term, pain can be coped with to some extent, but day after day, the experience of chronic pain may make it challenging to complete daily activities like chores or work or even leisure activities. And I'll show on the next slide that for each type of pain, there's a different type of treatment. Often, combinations of medications with non-drug treatments are better as they address different mechanisms that create the pain response. Many drugs, like some antidepressants and seizure medications, have been found to treat pain, even though that was never their intended use. And these can be used with more traditional pain medications. But always remember that simple things like heat and cold, exercise and rest, or cognitive behavioral therapies can really help. On the next slide, I want to reiterate that using multiple drugs from different classes helps, but using 2 or more drugs from the same class is not ideal. Instead, the approach should be to optimize the dose of one drug from a class, and then if further options are needed for pain management, to add on another drug from a different class. But this doesn't always happen in practice. For example, non-steroidal anti-inflammatory drugs, or NSAIDs, are a class of pain medications that are available with a prescription. Those are the drugs that are listed in the white boxes in the table, or they can be available without a prescription, and those are listed in the gray boxes. NSAIDs inhibit COX enzymes, which reduce inflammation and the chemical mediators involved in the pain response. Some NSAIDs are selective for just one of those COX enzymes that are present in the body, but there's not any benefit in combining different NSAIDs with different sort of selectivity for the different COX enzymes. And actually using multiple NSAIDs together doesn't increase your benefit, but actually only increases your risk of having an adverse event. Now, some adverse events related to NSAID use are simple things like heartburn, and it's not really a great big deal. However, there can be very serious adverse events related to NSAID use, and that includes things like gastrointestinal bleeding and cardiovascular events. In my own research, I looked to see if there was use of 2 prescription NSAIDs at the same time in a group of older Nova Scotian adults with dementia. And I found that over 20% of older Nova Scotian adults with dementia had at least one prescription for an NSAID. And that was looked at between the years of 2010 and 2015. But then looking at those NSAID users, 5% were receiving 2 prescription NSAIDs at the exact same time. And considering that some NSAIDs are available without a prescription, this is likely an underestimate of NSAID duplication. Moving on to the next slide, we'll talk about acetaminophen, which is another very common pain medication. And it's not necessarily like the strongest pain medication out there, but it works well, and in particular can be combined with other or stronger medications to minimize the dose of other pain medications that are needed. And that can be helpful because if you need less of a stronger pain medication, you can minimize those side effects like sedation that people sometimes experience when they're taking stronger pain medications like opioids. You might have actually done the combination of acetaminophen with an NSAID on your own because it can be very helpful for short-term pain relief or for when dealing with fever. But I have to point out that there are many different products available these days that contain acetaminophen. There are products like Tylenol arthritis, Tylenol sleep, Tylenol back pain, and many more. Actually, every image that's shown there on the screen contains acetaminophen. And while I do think acetaminophen is a very good and safe and effective medication, when it's used in high doses, doses that exceed the recommended amount, in the short term, very high, or moderately high, it can cause actually liver injury. So you need to limit the acetaminophen that you're taking from all sources to 4 grams or 4,000 milligrams daily. Or if you have a known liver condition, you probably want to limit acetaminophen use to 2 grams or 2,000 milligrams a day until you've had a chance to go over that with your family doctor or nurse practitioner. The problem is that even like over shorter periods of time when you're using too much acetaminophen, it can cause this liver injury. And it turns out that one of my 88-year-old family members had been really struggling with arthritis pain. And she thought that she had a good idea. In addition to taking regular Tylenol, which she had for years, she started taking maximum doses of Tylenol arthritis as well. And once we discovered this, turns out it had been going on for some time. She was able to stop taking 2 products, stick to the one, and followed up with her doctor, who followed her liver function over about 6 months just to make sure that there was no long-term damage being done. It's really important that that follow-up is done if you find out that you have been using too much acetaminophen for some period of time. You can move on to the next slide. And you'll see here I have the word dementia. And if you listen closely when I was talking about NSAIDs, I was talking about NSAID use in a population of older adults with dementia. I focus my research and my clinical practice on older adults, and in particular on those with cognitive impairment. Older adults with dementia may display behaviors as part of their illness, and these can be things like asking the same questions over and over, to more disruptive behaviors like wandering, shouting, or even being resistant or aggressive in their interactions with others. The fact that expressive language may be impaired can prevent the communication of pain, which instead may manifest as a responsive behavior. There are, of course, many possible causes of responsive behaviors. Pain's just one in the long list, which includes loneliness, fatigue, illness, and more. But if pain seems like it's a likely culprit, regular acetaminophen is a good place to start. You can give it 4 times a day, and over 3 days, see if there's any change in those behaviors. And if needed, stronger pain medications can be used. However, it's best to introduce these at low doses and increase slowly. Stronger pain medications like opioids can cause confusion or impair cognition further. We would always adequately treat pain in someone who has cognitive impairment, but by starting with lower doses and increasing slowly, you're able to titrate for adequate pain control and hopefully allow the cognition to remain stable and not see further deterioration in behavior related to excessive sedating medication. Let's move on to the next slide. And I'd like to bring us to the end of our journey with a few comments about pain control at end of life. Palliation or palliative care is a word we hear a lot in connection with end of life, but the definition actually isn't really about end of life. The definition is care that improves quality of life, prevents and relieves suffering, and really that might be the best approach for pain, particularly chronic pain that doesn't really have a reversible cause. Like the many types of pain older adults encounter, pain at end of life is, one that is there and is encountered, and it needs to be carefully planned. And the pain management strategy that's used at end of life should match with the wishes of the patient. These decisions are complex, personal, and it means that the palliative care pain approach that you see at end of life for one loved one may be quite different in another situation. Opioid medications are commonly used at end of life, but they're also used by many people, day to day to manage pain. If you or your loved one uses opioid medications, it might be something to look into getting a take-home naloxone kit. Naloxone's an antidote for opiate medications. These kits are available at community pharmacies at no cost, and they can be good to have on hand. In general, you hope you'd never have to use it. And in general, most people don't ever use these. But the situation that I think could sometimes happen is someone gets confused, and 30 minutes after they've taken one dose of medication, they by mistake take the next. And all of a sudden, if they have problems with their breathing or they seem more sleepy than they need to be, then this medication kit is on hand if it needs to be used while you're waiting for emergency health services to arrive. Now let's finish off with the last slide. I want to remind us that we often use combinations of medications to manage pain, but it shouldn't be combinations of medications from the same class. If a medication's not working to manage pain, it can likely be stopped. Pain treatment's not like high blood pressure treatment. In high blood pressure, you take your medication and you may not feel that it's doing anything, but if you measure your blood pressure, you'll be able to see that, yes, indeed, that blood pressure has come down. If your pain medication isn't helping to treat your pain, it's not offering any benefit, you can likely stop that medication with a little bit of guidance from your family doctor or nurse practitioner to help you do a taper appropriately. Remember that pain may manifest as a behavior change in older adults with dementia. And finally, pain treatment is going to differ from one person to the next, from one case to the next, even at the end of life. So it can take time for an optimal plan to be found and implemented. I'd like to thank you all for listening and for your attention.
Thank you, Shanna, for your important work in managing pain later in life. I so appreciate your time. And thank you to all of you for making quality of life of each of us a priority research area. I'm sure I'm speaking for everyone here when I express my gratitude. Relieving suffering is critical, and pain management should be infused into all aspects of managing our health and wellness. Now, during the presentations, we received a few questions, and thank you so much to the audience for your participation. We'll try and get through as many as we can. So let me just see our first question here. First one is from Patricia McDonald. Any advice on a senior with extreme chronic arthritis pain? Doesn't do well with prescriptions that have been given to her? Are there any new meds on the horizon that might help her and not cause unpleasant side effects?
So like I said, pain treatment plans are very individual. I also would wonder if this person's explored non-medications for their pain management. I find a lot of older adults have some success when they're using physiotherapy with someone who's trained in the management of older adults. I've seen success with, I think it's called TENS, and also acupuncture as a component of the physiotherapy. Of course, too, there's so many different medications out there. It's hard to give any advice on not knowing what she's tried, what she hasn't tried, what their medical conditions are on there. It sounds like there's a lot of opportunities and options, and probably looking into some of the non-medication or team managements in her location is probably the next step.
Great, thank you. Let's see if we have another question here from the audience. Okay, this one is for Dr. Chambers. How can parents best advocate for their kids when it comes to pain management? And at what level should they be insisting on this support?
Yeah, it's a great question. And, I think there are a couple of pieces to this. One is that parents should just be aware and informed that pain management is an option. And, I tell parents that they shouldn't be afraid to ask. I think, again, there's often this assumption that everything possible is already being done. And we've seen, as I indicated in my presentation, a huge transformation in care. But even still, very few children and parents realize that there are strategies, pharmacological, physical, psychological, that they can use before they take their kids for vaccinations. And in fact, a lot of parents give Tylenol before you go for a vaccination, which is actually not recommended. So we were part of a clinical practice guideline. There's evidence to show that giving acetaminophen before a vaccination could actually interfere with the efficacy of the vaccine. So you can give it after, but not before, and use some of the other strategies before. So I tell parents the best way to advocate is to simply ask what are we going to do about my child's pain, or what can we do about my child's pain? Because even in an emergency department, it just sets an expectation that I'm expecting my child's pain to be managed. And sometimes that question alone is enough. We have lots of resources for parents on our kidsinpain.ca website, as well as my research website, itdoesn'thavetohurt.ca. And we encourage parents to share over social media using the hashtag #itdoesn'thavetohurt. Lots of parents, lots of people sharing their stories and tips for others that come from evidence.
Great. Thank you so much. All right, let's look for our next audience question. Dr. Rosen, you talked about the prevalence rates, yet still many women are not seeking treatment or getting a diagnosis. What do you think these gaps still persist, and what can we do about it?
Sure. Yes. I mean, this is the challenge that I feel like I face in this work every day. We still have an issue of stigma and difficulty bringing these topics up. And what ends up is we kind of end up in this bind of silence where the woman or the patient might be hesitant to bring it up. They feel a bit embarrassed or shame. And doctors sort of think, well, if it's an important issue, if it's important to the patient, they're going to bring it up. So then they don't bring it up either. And we have this sort of reinforcing system of silence happening. So I think that, it is up to the healthcare providers to increase their knowledge around it and to ask questions about sexual function in a more routine way and frequently at various appointments, not just the first time when you're first meeting a patient, but also like regularly in sort of annual checkups to try and break down some of that stigma and silence. Also more education really in medical programs and more attention to this as an issue in public domains like today, because there's really recent data still suggesting that two things happen. One, women have been living with the problem for many, many years and didn't really know it was something that there was a name for it and a diagnosis and potential treatments. And also at the same time, once they do start trying to seek some treatment, the average is still seeing 5 healthcare providers before hitting on someone who knows what vulvodynia is and can make some recommendations and some treatment. So by the time they find that person, that's a lot of invalidating experiences that have built up over time. So we really need to get to a place where healthcare providers are more knowledgeable about this particular problem.
Yeah, I agree completely. As someone with endometriosis, I've had those invalidating experiences, so I can understand why women would stop asking the question. So I appreciate that.
Yeah.
Any other questions here? We have another. Dr. Treneman, if an elder parent or loved one is living with dementia and can't advocate for themselves, how can we be assured that their pain is being well managed?
That's a good question. I think when people are living with cognitive impairment or dementia, it depends a little bit on the stage of dementia they're at to know. Sometimes people are still able to communicate that they have pain, or if you ask they have pain, they'll be able to sort of point and you can get some sort of sense that way. When you lose those verbal cues, all of a sudden you have to really rely on behavior. So if people are settled and calm and they're doing well in sort of the day-to-day, then you can feel pretty confident that that pain is probably being quite well managed. That person is calm. However, when these behaviors start to present and people are yelling or wandering about or seem really agitated or hard to settle, that's the time you have to start thinking, is it possible that pain is a component? Many times it's not, and sometimes it is, and it's just hard to work through the step-by-step to determine what that root cause is.
Great, thank you. Do we have other questions? All right. Okay. From Nancy Pitts. Dr. Treneman, in the elderly, how can existential pain be recognized or differentiated from physical pain? Can you offer comments on approaches to existential pain and watching a loved one dealing with this?
That's a very difficult situation to be in. And if you're in that, my heart goes out to you. It's really tough. There's a lot of grief involved in that, right? On both people's parts, because there's a lot of grief for like the experience of pain and what that has robbed from a life. And there's also that grief related to the loved ones who are watching and grieving for the person they care about. This is where combinations of treatments come into really big effect. Sometimes folks who are dealing with that existential component to their pain really benefit from more of the psychotherapy from like perspective of like like actual treatment, and then like psychopharmacotherapy. So like medications that are working more in the brain. So think of like the antidepressants that are used and successful in pain management. But there's also, depends on like the individual's ability to get around. And COVID makes this so hard, right? Because we can't have those relationships that are really, really helpful and soothing. And it can be harder to get exercise at this time because the malls and places where people were walking aren't as accessible right now. So this is a very challenging situation, especially at this time. But I think that looking at multiple ways to come at this pain from perspective of regular pain medications, perhaps looking at like medications that are active in the brain, like antidepressants and those sort of non-typical pain medications in combination with sort of the other things that bring that person joy, like putting it all together. Yeah.
Thank you. Thank you so much. Next question we have is for Dr. Chambers. What do you think are the biggest barriers that continue to be an issue related to pain management in children?
I mean, I think probably the biggest barrier is just our continued belief that pain is just part of life and should be, suffered through and endured. Pain just isn't given the priority that it always deserves in our healthcare system. And I think that happens at multiple levels. I mentioned in my presentation around, how, healthcare providers, physicians don't necessarily receive a lot of training about pain. And when you think about the sort of even age of our workforce in healthcare, there are people who trained at a time where, pain was not given a priority and wasn't prioritized. So, I think that, and I had to laugh when Natalie shared the comment about, barriers at multiple levels with women's pain. There was a study in Pediatrics that showed they asked pediatricians and parents why they weren't using strategies to help manage even vaccination pain. And the pediatricians said, well, the parents aren't asking for it. And the parents said, well, the pediatrician's not recommending it. So it's exactly the same pattern where people are not asking. And so I think issues related to awareness and importantly, long-term impact. I think we need to talk about this more. And this is where the developmental literature is so useful. Like pain management is not just a nice thing to do. Pain, suffering through pain does not make you tougher or stronger. A lot of people brag about this in our society. But we know from human studies and animal studies that poorly managed pain early in life can change your whole trajectory. It changes the way your brain and your body experiences pain, makes you more at risk for later pain. So lots of barriers there. But as Natalie said today, these kinds of opportunities to shrink the gap between research and public awareness, I think are so important.
Wonderful. Thank you. We may have time for one more. Dr. Rosen, sounds like many couples might not even know that treatments are available out there. Where should these couples start?
So I've definitely mentioned this a little bit already, but I think it's really important to get connected with a healthcare provider that's knowledgeable about this pain. So it could be your family doctor, or you could ask for a referral for a gynecologist who, and gynecologists do generally, receive more extensive education in this area than family doctors might. You might consider also searching for a pelvic floor physical therapist or a sex therapist in your area who would also have expertise and be knowledgeable to help sort of you navigate where to start and how to get connected with healthcare providers who can make recommendations for treatment. On my website, I also list some resources, some websites and some books that would help people start to learn a bit more about the problem, which will make it easier to then advocate for yourself. And then the last thing, that I would say is that if you're in a relationship, talk to your partner about it, decide on sort of some next steps together, because it's a great start for not feeling alone in this issue and making sure that the two of you are on the same page, so that you can, tackle some of the next steps together.
Great, thank you. I don't think we have any other questions. Just want to give the panelists, we have a couple of minutes. If you had any last thing you wanted to add before we sign off. All good? Great. You guys did a great job. I know 10 minutes is just, gave us a brief view of your immense research. So thank you. And I want to thank everyone for joining us today and for taking the time to learn about this important research area. I'm sure every one of us can think of a time in our lives where pain deeply impacted our own well-being or that of a loved one. This discussion today proves that there are people out there studying the many complexities of pain for the betterment of our own lives, and we so appreciate that. I know I'm personally grateful, and I'm sure many are today who are here. Special thanks to our participants, Dr. Christine Chambers, Dr. Natalie Rosen, Dr. Shanna Treneman. We appreciate the immense education, time, and dedication you put into your work. Also, thank you to our viewers who tuned in today, hopefully on your lunch break, or maybe you still get your lunch break after this. And on behalf of Dalhousie Medical Research Foundation and Dalhousie University, we wish you health and happiness. Stay safe, and thank you for joining us.